Hey guys, it's Tanya Creaky again. Welcome to our last class session. Today we're going to be rounding out our pharmacological session with miscellaneous antibiotic drugs. Our objectives for today are to identify and discuss core drug knowledge and core patient variables as they relate to the interactions and adverse effects of fluoroquinolones such as ciprofloxacin, cyclic peptides such as daptomycin, and then polymyxin B. We're also going to interweave their nursing care plan and patient and family education issues or concepts for these appropriate medications. For a quick review, let's talk about microbes. One cell, multicellular organisms. They're capable of producing diseases, and when they do, they're appropriately called pathogens. Now, pathogens can be, or microbes that cause pathogens can be bacterial, viruses, fungi, parasites, etc. And when they do cause disease, and we want to treat those diseases or symptoms of those diseases, the treatment is classified by the organism. Therefore, bacterial infections are treated by antibacterials. Fungal infections are fungal infections are treated by antifungals. Parasitic infections are treated by antiparasitic agents. Now, antibiotics are also classified as bacteriostatic or bactericidal. Bacteriostatic is where we are stopping that mechanism. Bactericidal is where we are killing the bacteria or the microorganism. Now, antimicrobial drugs work in a variety of ways. We have talked in previous classes about all of these others: inhibition of bacterial cell wall synthesis and protein synthesis, inhibition of metabolic pathways, disruption of cell wall permeability, and inhibition of viral enzymes. Today, this particular classification, the miscellaneous drugs, they work by inhibiting the nucleic acid synthesis. As such, we know many bacteria use enzymes for replication that do not exist in human cells. The DNA gyrase is an enzyme that's needed for bacterial DNA replication. So in a bacterial cell, the nucleic acids DNA and RNA, the deoxyribonucleic acid and the ribonucleic acid, are very important molecules. When the cell divides, it replicates the DNA and gives that new cell its instruction manual. Basically, it's the script. It's what that cell is supposed to do. If the DNA or the RNA synthesis is inhibited or stopped or blocked, the cell won't be able to get anything done because it won't have the script. It won't know what to do. Quinolones inhibit DNA replication. They actually interfere with that DNA synthesis. They stop that DNA gyrase, and in so doing, the bacterial cell numbers are decreased. They're killed because they cannot reproduce. The prototype for the quinolones is called ciprofloxacin, or more easily termed Cipro. Quinolones are synthetic antibiotics that are effective for gram-negative and gram-positive bacteria. The first generation of drugs were called quinolones. And as methods improve, technologies improve, research occurs, things are added, things are taken away. So there have been subsequent generations of quinolones. The one we're currently working with are called fluoroquinolones because a fluorine atom has been added to the quinolone structure of these drugs. And in so doing, according to Ashton, Brenner, and Venable, it allows for those medications to treat more things. So, for example, the first generation quinolones only treated uncomplicated urinary tract infections. The second generation ones increased and treated gram-negative and systemic issues. The third generation of quinolones had extended activity against gram-positive pathogens, but they were less effective against Pseudomonas, for example. So the fourth generation quinolone, which is where we are right now, have extended activity against Pseudomonas as well. So the onset of these medications, so they are treated, the indications for treatment are gram-negative bacteria, group D strep, typically urinary tract infections, respiratory infections, joint infections, gonorrhea, anthrax is another, typhoid fever. These are the indications if someone presents with that particular type of infection. then ciprofloxacin, or Cipro, is typically prescribed. So Cipro is administered orally, parenterally, or topically. It's excreted by the kidney, and the onset depends upon the route. So we can find anywhere, like for example, in IV administration, the onset would be about 10 minutes, going right into the bloodstream. The peak occurs between 30 minutes and 2.5 hours, and it's important to note that the absorption of Cipro is reduced by antacids. So we want to caution our patients not to take antacids at the same time they're taking Cipro. It's also important to note that organisms may not continue to grow for 2 to 6 hours after exposure to Cipro, which means they have a prolonged post-antibiotic effect, which is a good thing. Some contraindications and precautions that are important not only for us as healthcare providers to know, for us to communicate to our patients, are as follows. Pregnant and lactating women, we need to be very mindful. We're not sure. Research is not definitive on whether this medication does cross over into the breast milk. If the patient has any hypersensitivity to any components of Cipro, they should not take it. For example, any oxacin, OXACIN medication, if they've ever had an allergic reaction to, then they should not take Cipro. Children younger than 18 should only use the ophthalmic solution or the ophthalmic treatment, or oral only for UTI, but no other reason. Caution should be used for those patients with renal and hepatic dysfunction, anyone on Coumadin therapy or anticoagulant therapy. We might want to be very mindful. The adverse effects that we need to share with our patients, the most significant side effect would be black label warning of tendinitis or tendon rupture. That typically occurs in those individuals that are 60 years or older, or have renal dysfunction, or those that are taking anticoagulant therapy. So we need to be really mindful. More common side effects would be nausea, vomiting, diarrhea, abdominal pain, restlessness, maybe bad taste in the mouth after they have taken the medication, and then some symptoms of photosensitivity. So we want to be mindful for those patients that are spending a lot of time in the sun. They need to protect themselves with a hat or using sunscreen. Because oral quinolones interact with antacids that contain calcium, magnesium, iron, they need to make sure to take those medications, those antacids, at least an hour before or an hour after taking quinolones. That way it does not decrease the absorption of Cipro, and we should get the desired effect within the appropriate time frame. However, if they are taken at the same time, then it's going to be a prolonged effect. Use of this medication and other antibiotics can lead to subsequent infections like yeast infections. So the patient should alert us if they have any white pearls on their mouth or white patches. That could be an indication that they are experiencing a yeast infection, or if there's a change in their vaginal discharge. Another severe adverse effect or reaction is an intestinal condition called Clostridium difficile. It's a type of bacteria-resistant diarrhea. It can be while the patient is being treated, weeks or months after treatment, and the hallmarks are persistent diarrhea, abdominal or stomach pain, bloody, watery diarrhea, cramping. So they should stop the medication right away and contact their physician if that does occur. In regards to core patient variables, we certainly want to get a good medical history on the patient. We want to ask them, their age, if they're pregnant, what their dietary habits are. For example, according to Ashenbrenner and Venable, we want to evaluate for pre-existing GI disease, renal or hepatic dysfunction, and we want to get baseline blood testing information in order to ensure that we're not increasing their risk if they have some precautionary health concerns. Doing a physical exam, we want to assess their skin for rashes or lesions, any respiratory issues, and then any blood dyscrasias or abnormal lab values. Again, Cipro does cross the placenta. We're not sure if it enters the breast milk, so we do want to exercise caution there for pregnant moms. For the elders, we want to monitor if they have renal or hepatic disorders, since Cipro is excreted via the kidneys. Now, as far as dietary habits are concerned, caffeine may inhibit the action of Cipro, so we want to caution our patients that they should minimize their caffeine intake, whether it's coffee or tea, soft drinks, what have you. And acid and vitamin use, as I mentioned, antacids previously, they should be taken an hour before or after Cipro. If they're doing a multivitamin of any kind, that can also decrease the absorption. So they should take vitamins 2 hours before Cipro so it does not negatively impact. In regards to the ophthalmic solution, we need to teach our patients not to touch the tip of the bottle with their finger or with their hand or even onto their eye, which of course will cause contamination. And on occasion, patients are treated at home with a home health nurse because it can be parenteral, but primarily when patients are at home, they are treated orally with oral medication every 12 hours and they should take it around the clock. Nursing diagnoses, basically these are related to potential adverse effects, and we want to ensure that our goals are in line with maximizing therapeutic outcomes of our patient. So diarrhea related to adverse drug effects, our outcome is we want the patient to maintain fluid intake and to avoid dehydration. Obviously contact the prescriber if diarrhea persists. Imbalanced nutrition due to alteration in taste or GI effects, our desired outcome is the patient will maintain adequate body weight. And then risk for injury related to drug-induced dizziness. Our outcome is we want the patient to remain free of injury, free of falls, and of course notify the physician if they have any of those CNS disturbances. From a planning standpoint, we want to ensure to maximize therapeutic effects, but also minimize adverse effects. So to maximize, we want to ensure that the patient understands the importance of taking this medication around the clock until it is completely gone. Even though they may start feeling better, their symptoms may improve, we need to have a full course of treatment. We also want to review the culture and sensitivity to ensure that we are treating the appropriate medication with the appropriate treating with the appropriate medication the bacteria that we have identified. Also, for those patients that are taking multiple medications, and we know there's a polypharmacy issue in our country, we want to ensure that we minimize drug interactions. So patients that are on anticoagulants or antacids, we want to make sure that they're taking them appropriately and understand the importance of doing so. To minimize adverse effects, again, safety measures, to notify us if they have dizziness, not to operate a vehicle, large machinery if they're feeling dizzy, GI upset, small frequent meals, or ice chips or mouth care if they have stomatitis, which is kind of an inflammation of the oral mucosa. According to Aschenbrenner and Venable, stomatitis and sore mouth can be relieved with mouth care and ice chips appropriately. I've mentioned already a lot of the patient and family education components as I've been sharing the information throughout, but one of the primary ones is that our patient and or family should report any tendon pain immediately because it could be an indication that they are having tendonitis or tendon rupture. They should not take any medications with the oxycin, especially if they've had a previous allergic reaction to some sort of fluoroquinolone. If they're pregnant, not to take it because it does transfer over the placenta. Breastfeeding, we're not sure if it does cross over into the breast milk. So we want moms to be especially aware and they can make the decision accordingly, but we want to guide them accordingly. Again, complete full course of therapy every 12 hours. So we want to make sure our patients are taking the medication 12 hours apart. So if they go to bed at 9 o'clock at night, we don't want them to take the medication at 10:30 in the morning because then they'd have to wake up at 10:30 at night in order to take that second dose. So if they take it, 8 o'clock in the morning, they take it 8 o'clock at night before they go to bed. Also, we want them to take the full course of therapy, full course of treatment because of the positive effect. But on occasion, we do have some patients that just don't do that. So we want them to understand the importance of not utilizing that leftover medication for an infection of some different kind down the road, because we don't know that Cipro is going to treat the other infection, and we certainly shouldn't be sharing medications with other people for the same reason. They should be aware of allergy symptoms, and those would be fever, shortness of breath, swelling of the face or tongue, itching, rash. If they have any allergic reactions, they should stop taking the medication right away and call their healthcare provider. Guide them to relieve GI upset. Small frequent meals will do it. They can take the antacids, however, an hour before or after. And then they should know that to not be exposed to the sun for too long. If they're out in the sun, wear a hat, wear sunscreen in order to protect them in that respect. Ongoing assessment and evaluation. We want to empower our patients and their families with information and knowledge in regards to monitoring for therapeutic effects, for understanding what the adverse effects of this medication is, but also to understand that opportunistic infections or superinfections are common, and that a candida or a yeast infection can occur whenever they are taking any antibiotics. And so they should know, again, closely monitor for those actions. And then also that diarrhea may be an antibiotic associated pseudomembranous colitis. And again, we talked about that, the bloody, watery, painful abdominal cramps. That would be an indication that, again, they need to stop the medication and contact their physician. Okay, lots of information. Here's what we love best. Test time. All right, question number 1. During an IV quinolone therapy treatment in an 88-year-old patient, which potential problem is of most concern when assessing for adverse effects? A, hepatotoxicity. B, rhabdomyolysis. C, tendon rupture. Or D, nephrotoxicity. Okay, let's see what you thought. Raise your hand, raise your hand. Okay, the answer would be tendon rupture. As previously stated, there is a black box warning required by the Food and Drug Administration for all quinolones because of the increased risk of tendinitis and tendon rupture in the use of these drugs. It is more common in those individuals over 60 years of age, patients with renal failure, and patients that are taking glucocorticoid therapy like prednisone, according to Ashenbrenner and Venable. So we want to make especially certain that we get a good health history from our patient. The next drug that we're going to talk about is daptomycin. That's that cyclic lipopeptide. Now, that is the only drug in this new class. It's also called Cubicin, and they're not really sure what the mechanism of action is. However, they do know that it binds to gram-positive cells in a calcium-dependent process and disrupts the cell membrane potential. And of course, if it disrupts the cell membrane potential, it interferes with the integrity of the cell wall. It inhibits protein, blocks it. It inhibits DNA and RNA synthesis, leading to cell death, very much like we talked about earlier with the ciprofloxacin. We also know that it's used to treat complicated skin and soft tissue infections caused by susceptible gram-positive bacteria, including MRSA, methicillin-resistant Staph aureus, also VRE, vancomycin-resistant enterocolitis. Daptomycin is administered IV once a day, and it's excreted by the kidney. The contraindications that we need to be mindful for here are hypersensitivity, if the patients have any pre-existing GI disorders, and that's important because they may alter the normal GI flora, causing that pseudomembranous colitis that I spoke of earlier. We also want to make sure or ensure that the patient doesn't have any pre-existing myopathy or peripheral neuropathy. The reason being because that is muscle weakness, pain associated, and if they're already having these concerns, then we certainly don't want to prescribe something for them that's going to make a bad situation worse. Again, using caution in those breastfeeding women as well. Adverse reactions would be constipation, diarrhea, nausea, vomiting, injection site reaction. So we want to ensure that the injection site is not red, irritated, angry, inflamed. Additional CNS issues, headache, dizziness, hypertension, hematopoietic anemia, thrombocytopenia. We have electrolyte imbalances, elevated CK, INR, and I'm going to speak to that in just a couple of minutes, and MS. Musculoskeletal, arthralgia, back pain, myalgia, osteomyelitis. Lots of potentials here, so we want to make sure that our patient is well aware. We also know that there are a couple of drug interactions. Daptomycin may interact with drugs that cause myopathy. Statins, those lipid-lowering medications, actually inhibit the enzyme HMG-CoA reductase, which plays a central role in the production of cholesterol. And they also have an interaction with warfarin. Coumadin, it can increase the patient's INR, according to Fuchs, 2018. The core patient values here that we need to be mindful of, again, assessing for contraindications and precautions, renal insufficiency history. We need to review. The assessment should include lab values, prior to therapy initiation to ensure that the baseline data for comparison after treatment is initiated, according to Aschenbrenner and Venable. Now, it's important to know we want to review the CBC, the complete blood count, renal function test, and again, CK, which is creatinine kinase. Lifespan and gender, pregnancy category B, caution for breastfeeders, not to be used in children, just like on the Cipro side. And geriatric patients may need a reduced dose due to renal insufficiency. Regarding nursing diagnoses and outcomes. Well, there may be acute pain related to myopathy, so our desired outcome will be the patient will contact the healthcare provider if pain or tingling in the extremities occur, because that could be an indication that they're having myopathic issues. Imbalanced nutrition, less than body requirements related to nausea, vomiting, diarrhea, dyspepsia. We want the patient to maintain a consistent body weight, and again, contact the healthcare provider if the effects are persistent. And then there's a risk for infection related to overgrowth of organisms. As we spoke of, the patient will report the signs of superinfection to the healthcare provider. And those superinfection signs and symptoms would be abdominal cramping, fever, diarrhea, bloody stool, nausea, dehydration, poor appetite, and elevated heart rate. So if the patient experiences any of those issues, they need to contact the healthcare provider right away. In regarding to maximizing therapeutic effects and minimizing adverse effects, we want to review the culture and sensitivity to ensure that we're treating the appropriate bacterial infection, the appropriate medication. Visually inspect the daptomycin. So in the vial, we want to make sure that it's clear that there are no particulates or discoloration. If there are, we do not want to use it. Do not use it if it's cloudy at all. Daptomycin should be administered with either normal saline or lactated ringers because it is incompatible with dextrose-containing solutions, according to Aschenbrenner and Venable. Again, those key issues, those are very key in order to assure that we're not going to have any adverse effects. Also, this medication should be infused over 30 minutes without any additives, and the line should be flushed before and after administration. It can also be administered IV piggyback over 2 minutes without any adverse effects. Minimizing adverse effects would be to evaluate the IV site pre-administration to make sure there are no issues, no irritations, no redness, no edema. Teach the signs and symptoms of potentially severe adverse effects, and we've talked about those in regards to diarrhea, muscle pain, tingling, dark-colored urine, and fatigue. They should be reported immediately. And then frequent mouth care with ice chips in order to minimize or decrease the condition or the symptoms of stomatitis. Patient and family education. Explain potential adverse effects and why they should be monitored. We've talked about those. Report diarrhea, muscle pain, tingling. We've talked about those. Stop taking the statins until further notice. We've kind of talked about those. Ongoing assessment would to evaluate for resolution of infection. So we're on the medication. We want to make sure that we get a clear, all attaboy, all everything is good, that the infection has been resolved. And there should be a weekly CK, a creatinine kinase. Creatinine kinase detects and monitors for muscle damage. So this helps us to diagnose any conditions that are associated with muscle damage. Like, it's important to know that elevated CK or creatinine kinase could be related to an elevated risk for heart attacks or an indication for rhabdomyolysis. So the healthcare provider should be notified of any myopathic symptoms, and if the CK is 5 times the upper limit of normal. And of course, by the end of daptomycin therapy, infection and adverse results should be resolved. The CK information reference is lab tests online in regards to the creatinine kinase. All right, one more question. Okay, now raise your hands, get ready. You're caring for a 62-year-old patient, a postal employee who was exposed to white powder on a package he was delivering. The substance was confirmed to be anthrax. So we now know the patient has been infected with Bacillus anthracis. The physician has ordered Cipro as the antibiotic of choice. What adverse effects should you advise the patient and family to seek medical attention for? A. Headaches. B. Hallucinations. C. GI reactions. Or D. Photosensitivity. Okay, I'll give you a moment. Here we go. Do, 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 do. Okay, raise your hands. Let me know. Are you ready? Here we go. According to Abramovitz, 2018, the response is hallucinations. Now you might be thinking, but wait a minute, you just told me all of those things were adverse effects of Cipro. Well, they are. However, any CNS stimulation effect, adverse effect would require medical evaluation. So, headaches, GI reaction, photosensitivity, we can pretty much take care of those things on our own. But hallucinations, something major is going on, and we need to bring that to the attention of the physician. Other CNS stimulation adverse effects may be acute psychosis, agitations, or tremors. Good to know. Our last medication is going to be polymyxin B. Polymyxins are older antibiotics. They're different from quinolones and fluoroquinolones and cyclic lipopeptides, according to Aschenbrenner and Venable. And they are indicated for gram-negative bacteria, except Proteus and Neisseria. They're used in combination with polytrim or neosporin. They're typically administered topically or ophthalmically or otically, ear, eye, skin. They're not typically used systemically because they can cause nephrotoxicity or neurotoxicity, but they can be used as a urinary tract irrigant in conjunction with neomycin. So we know that these polymyxin Bs bind to phospholipids in the cell membrane of gram-negative bacteria and again increase that permeability of cell membrane, which decreases that DNA and RNA synthesis and then inhibits that synthesis and kills the cell. So, having said that, we want to take a look at a resource that I have created for you. I'll go ahead and put my references up, but I did create this resource. This is a teaching tool, not only for you, my students, but also for our patients. Oftentimes, information, just like what I provided here, comes at you at a rapid rate, and we might miss a few things. So I decided to develop this teaching tool, kind of a walk away, a takeaway, so that you would have it handy, not just for your own edification, but also to be used with your patients. It's very easy to sit at the bedside and tell people information, but they typically forget what you've said. But if we can give them a brochure, a handout, a pamphlet where they can, flip through at their leisure, then it may help things to stick. So, miscellaneous antibiotic drugs. Antibiotics, what are they? It speaks to fluoroquinolones, it speaks to ciprofloxacin and daptomycin. So it kind of gives a breakdown of all the things that I've covered in this video. And then on the very back, it talks about common side effects. So I'll read this quickly. Not all antibiotics are created equal. As specific as they are to the microbes they attack, their side effects are specific as well. However, there are a few common side effects related to most antibiotics. So, according to the CDC, antibiotics commonly cause rashes, dizziness, nausea, diarrhea, yeast infections. And those are some of the same things that we talked about in the presentation. Ciprofloxacin, daptomycin, polymyxin B, they all have indications and uses, and we need to know what they are. We need to know what the contraindications are, the precautions are. We need to know how to help our patients to know what to and what not to use, and how not to put things together that can create problems for them. This is just a tool or a resource that I've developed for you to use. You can actually find this in your Canvas shell. Go ahead and print it and use it in your clinical settings. Our contact information and references are on the back in case you want more additional information. Thank you so much for taking time out to spend on our last class in regards to miscellaneous antibiotic drugs. You have a great day. Look forward to seeing you soon.